Dr. Hari Kumar Srirangam.
Morning. Good morning to everyone. My topic is about ocular thunderstorm, measles retinopathy. So, measles is caused by paramyxovirus that is highly contagious and typically contracted in childhood. So, most serious systemic complication can have encephalitis. So, in acute retinal stages, the patient can have the macular lesion like macular edema, then PED, choroiditis, or whitish retinal infiltrate. So, I am presenting a one case and I am doing review of literature. So, 15-year-old male patient presented with sudden loss of vision in the right eye for last 3 days. So, on examination, the anterior eye was 1 by 60. So, you can see here on presentation fundus, the vitreous and well demarcated yellow subretinal lesion of varying size in the mid peripheral retina. So, clinically, we suspected this case as a viral retinitis and started on oral valsaclovir 1 kg BD. So we did couple of investigation. So all this investigation, IgG came slightly raised, and all things came negative like VDRL, HIV, TB, and leukocyte count also came normal. The tuberculosis profile also came negative. So after starting valsaclovir, after 1 week, you can see here there is a resolution of lesion, but still there is a retinal thinning and necrotic area present in the right eye. And in the corresponding OCT, you can see ballooning of ILM, the nasal to the fovea. And there is a completely disorganized inner and outer retinal layers. And in the left eye, you can see here loss of complete photoreceptor layer and completely disorganized retinal layers. So here, the right fundus picture, you can see here a whitish kind of lesion in the rate-free filter photo, which appears to be snowflake kind of lesion over the macula. So that's why we term this condition as a snowstorm-like exudative retinopathy, which is not reported earlier. So after 2 weeks of treatment, you can see here a resolution of a lesion, reduction of size of retinal lesion and retinal hemorrhages, left eye having pigmentary changes in the macula. So after 4 months, FFA was not performed initially because the patient have a renal parameters little bit high. So that's why we avoided that. But after 4 months of follow, we did FFA. So in that FFA, it came as a diffuse hyperfluorescent area over the macular site, because of dye field staining area. So they are completely atrophic retina with pigmentary changes. So we suspected this case as a healed viral retinitis. So, but some clue was there like a behavioral change, which gives us like there can be other causes. So there was no any history of vaccination in the birth. So we advised EEG, MRI brain, anti-measles antibody titer, CSF tap for antibody, and also we did CSF analysis, MRI brain and EEG. So on EEG was normal, MRI brain was diffuse cerebral atrophy. On CSF analysis, it came as an anti-measles antibody IgG titer was raised, and anti-measles antibody serum titer also was raised. So clinically, because of patient having behavioral changes and the CSF antibodies was raised, so we suspected this case as a measles. Though the Dicken's criteria having several other criteria like brain biopsy and other things, but here two criteria were matching, like CSF antibody titer was raised and there was a behavioral changes. So we diagnosed this case as a patient having measles retinopathy with CNS involvement. So these were the earlier case report. So you can see here, there are only 3 case reports who give a fashion of basically how the major cytometry courses. So you can see here, large focal retinitis was earlier reported, but nobody reported widespread retinal necrosis in the macula. And also we got a very typical feature like snowstorm-like exudative retinopathy, which was not reported earlier. So on conclusion, the mesial retinopathy is always considered in a young patient, even if the classical finding of mesial retinopathy are not seen in the patient. So mesial retinopathy should consider in cases with unusual necrotizing cases, even if the clinical findings of CNS involvement do not exist. This case sheds light on unusual course of mesial retinopathy. Multimodal imaging like optical coherence tomography guided us in treatment and assessment of severity of injury. Thank you.
Thank you. Dr. Harikumar Srirangam.
Good morning, everyone. Today I'm going to present a case of post-cranial graft vasculitis in patients with optic disc maculopathy. My case 1 is a 35-year-old male who presented to us with left eye gradual painless progressive diminution of vision. His BCVA in the right eye is 6/6 with anterior and posterior segment within normal limits. His BCVA in the left eye is 6/60. His anterior segment was within normal limits. The left eye optic disc left eye fundus showed optic nerve head with SMD with an OCT of CMT 1498 microns. Patient underwent left eye pars plana vitrectomy with PVD injection with scleral autograft with C3F8 injection and LA was performed. POD 30 showed left eye BCVA improved to 636 with the OCT reduced to CMT of 412 microns with the scleral graft in situ. POD after 3 months, patient presented with left eye pain, redness, photophobia since 1 week. His BCVA reduced to 5/60. On anterior segment examination, he showed circumciliary congestion with occasional cells and flare with anterior vitreous cells of 3+ with scleral graft in situ with cotton wool spots at the posterior pole with sheathing of vessels in the nasal quadrant. Patient underwent extensive uvetic workup which were negative, and the patient underwent FFA which showed extensive CNP areas in the peripheral area with diffuse vascular leakage and staining of the vessel wall. Patient was given posterior PST triamcinolone along with topical steroids. On subsequent visit, the inflammation was not reduced, so patient was started on oral steroids, tapering dose of oral prednisolone 1 mg per kg. At 6 months, patient BCVA improved to 624 with vitreous haze reduced with SRF regressed. Coming to case 2, here is a 23-year-old male who presented to us with right eye gradual painless progressive diminution of vision since 7 months. Patient is a known case of lichen planus for which he was on cyclosporin immunosuppression for 1 month, and following which he was on low dose oral steroids. His BCVA in the right eye is 5/60 with anterior segment within normal limits. His right eye fundus showed optic nerve head pit with subfoveal detachment. This is the OCT of the right eye showing optic nerve head with SMD of 955 microns. The patient underwent PPV with sterile autograft with SF6 injection. At 2 months, again patient presented with pain, redness, photophobia is with an fundus findings of anterior vitreous cells with peripheral cuff and sterile graft over the ONH with SRF at the macula. On FFA, patient showed diffuse vascular leakage with vessel wall staining suggestive of vasculitis. Patient was started on dexamethasone on oral prednisolone 1 mg per kg. Optic disc maculopathy is a condition where you have macular detachment with lamellar or full thickness macular hole. The management can be either release of vitreous sanction with barrage laser to the temporal margin, or PPV with PVD induction or ILM peeling can be done. Ours is we have not used any extensive agents like intraocular dyes or antibiotics, triamcinolone or silicone oil or PFCL. This is a rare possibility of posterior segment inflammation in the form of occlusive vasculitis which has been observed. This is the first ever report which has been reported till date. Hence, early identification of the inflammation, prompt treatment with systemic steroids is very important. Thank you.
Kritika Garg, Dr. Kritika Garg.
everyone. My topic is pattern of uveitis in a secondary medical center at Panipat, Haryana. Uveitis refers to group of conditions in which inflammation affects the various components of the uvea, and proper diagnosis is frequently difficult because of wide systemic and ocular side effects. And if not thoroughly and promptly treated, it leads to irreversible sight loss, and it is a cause of 25% blindness in underdeveloped nations. In India, 730 out of every 1 lakh people are affected with uveitis. Hence, early detection and prompt treatment are crucial. So my study was a hospital-based retrospective study for 102 months. It was done on 65,126 patients, out of which 377 were diagnosed to have uveitis. The inclusion criteria was patients diagnosed with uveitis and patients whose data was available. The data of all the subjects was taken from the hospital records, and the findings of anterior posterior segment along with demographic information, laterality, type, etiology, course and length of the follow-up was noted. And in cases where intraocular inflammation was not indicative of recognized uveitic entity were referred to as idiopathic. So we found that the prevalence of uveitis in our area was 0.58% with a mean age of 42.28 years and a male predominance, and also the working class, that is 31 to 40 years age group, was the most commonly affected. And 84.62% cases were unilateral, 342 cases had acute onset, 24 had recurrent onset, and 11 cases were found to have chronic onset. And the cases of anterior uveitis were maximum and of intermediate uveitis were minimum. As we can see in this table, according in the various types of etiology, in the various types of uveitis, we could see that the most common etiology was idiopathic. So despite our advances in the knowledge and development of sophisticated diagnostic methods, the cause of uveitis is still unknown in many cases, and there has been research which has shown that various regional, demographic, and racial factors all have an impact on the pattern of uveitis. Therefore, an epidemiological study of the distribution of uveitis on the Indian subcontinent is likely to be informative and help suggest topics for future clinical and basic research into uveitis in a particular area, and would help in having a focused baseline investigations to examine the case of uveitis to arrive at accurate diagnosis, as unfocused lab testing could be time consuming, costly and ineffective process. So anterior uveitis is the most common entity in a hospital. The most common etiology was found to be idiopathic, and among infectious it was tuberculosis, and among non-infectious it was HLA-B27.
Dr. Smita Jas.
That's not the presentation.
Dr. Judah Samuel.
Good morning, everyone. Today I'm presenting a cause, an uncommon etiology for post-fever retinitis. So neuroretinitis is an inflammatory disorder of the eye presenting with optic disc edema and delayed development of a macular star, secondary to optic nerve swelling towards the macular structures. It was originally described by Lieber and Gass, and now it's divided into three non-infection causes: infectious and recurrent, which is usually idiopathic. Abdel Hakim et al. Divided the approach to the patient with neuroretinitis based on the laterality of presentation. So today we are presenting a 28-year-old male doctor working in an intensive care unit, medical intensive care unit, who has no previous ocular morbidity or systemic morbidity, who presented with a history of sudden onset decrease in vision and metamorphopsia in the right eye 3 months after a history of fever with generalized rash. His vision at presentation was 6/9. He had mild anterior uveitis, a relative afferent pupillary defect, and a patch of retinitis along the infratemporal vessel. So the diagnosis then was post-fever neuroretinitis. He was started on topical steroids and reviewed. He had a drop in vision as per the symptoms, but actually clinically he didn't have, though there was surrounding edema around the retinal lesion had worsened. Further blood investigations were done, and a differential diagnosis of rickettsial post-viral retinitis or toxoplasma was kept in mind, and a non-infectious cause of a Behçet's disease. He was started on oral steroids along with doxycycline. On review, his visual acuity had improved. He had no RAPD. His perilesional edema had decreased, and investigations revealed a high positive titer for anti-measles IgM and IgG. He was doxycycline was discontinued. We gave oral and topical steroids only, which were then tapered. A week after the presentation, the toxoplasma IgG also was positive, so he was started on Septran with infectious disease evaluation. The lesions resolved in about another few weeks, and we discontinued all the medications after adequate tapering doses. 6 weeks later, his visual acuity is 6/6, no anterior uveitis. He still had some persistent metamorphopsia, and all medication was stopped. So we know that neuroretinitis presents with impaired visual acuity, dyschromatopsia, relative afferent pupillary defect, visual field abnormalities. Etiology can cover bacterial, fungal, parasitic, viral, spirochetal, and inflammatory causes, which mean non-infections. Measles is an important cause for childhood morbidity, and it's a self-limiting disease. In the prodromal phase, they can have some ocular findings and very rarely posterior segment findings. Complications are what we saw earlier. SSP has some typical ocular manifestations. So here in summary is a young male with fever with rash, diagnostic of measles, post-fever neuroretinitis with high titers of measles infection, which recovered significantly. So it's important to take, even though it's a self-limiting disease, steroids are given to hasten visual recovery. It's important to take a detailed history, a good examination, and an appropriate treatment. Thank you.
Dr. Judas Samuel.
Respected teachers, judges, and colleagues, I will be presenting on a case of bisphosphonates associated uveitis. Bisphosphonates are derived from inorganic pyrophosphate and used in the treatment of osteoporosis due to its ability to decrease bone resorption caused by osteoclast. Horizon trial in 2007 reported fever, myalgia, headache, arthralgia in 32% of people following first dose of zoledronate injection. Estimated incidence of ocular inflammation following zoledronic infusion was between 0.46% to 1%. We present a 60-year-old lady who is undergoing treatment for type 2 diabetes, primary hypothyroidism, and osteoporosis post-menopausal since 2010. She presented to us 1 week after injection zoledronic acid, 4 mg infusion with acute onset redness, pain, photophobia in both eyes. On examination, she had bilateral acute non-granulomatous anterior uveitis, first episode, probably drug related. She was treated with topical steroids and resolved within 1 week. Discussion. Drug-induced uveitis is relatively rare occurrence. It represents less than 0.5 of uveitic cases in a tertiary eye hospital, as reported by Frankfurter et al. Drugs causing uveitis, systemic drugs like rifabutin, cidofovir, bisphosphonate, sulfonamides, and moxifloxacin, and topical medications, mostly anti-glaucoma medications like metoprolol, rimodulin, and prostaglandin analogs like mitaprost and tadalafil and travoprost. Proposed mechanism for the immune response seen during bisphosphonate therapy are M1 macrophage polarization, gamma and delta T cell proliferation, immune complex deposition. Gamma and delta T cells are present in the ciliary body and enthesis of mice, contribute to the strong association between aminobisphosphonate and anterior uveitis. Adverse effects of bisphosphonate in the eye are uveitis, which can be anterior or posterior, blepharitis, scleritis, and episcleritis. Orbital inflammation and optic neuritis has also been suggested. Ocular inflammation following bisphosphonate therapy has been reported since the early 1990s. Detailed history of medication is important in the diagnosis of anterior uveitis for appropriate management. Communication to the treating endocrinologist regarding the complication can prevent further recurrences. Thank you.